Welcome. Welcome to the last session of the day. And but this is a joint session. This is an organized session jointly organized by me and Jennifer. So we're going to make this like an old lady panel. So without further ado, this is for those people who just walking. This is a SOS session for Segment 1. And so here we have two excellent presenters who have enormous experience in this field and who are going to share with us the latest result as hopefully some personal experience, in terms of, how you get the social experiment implemented in the field. So without further ado,
a little bit puzzled because in the program you even don't know what we're talking about. You just know that this session is about social experiments in financing and in provider payment. So the talk that I'm going to give is called Aligning Provider Payment Incentives to Leverage Changes in Delivery System. And I'm going to present to you some work that we're doing in rural China on how we use provider payment incentive to try to change delivery. So what is this work motivated by? If you review the literature in provider payment, many of you sitting here are experts and have done lots of work in that. But I think that we might be at a time that we need to rethink about our research in provider payment method. Perhaps it is time for the next generation of work on provider payment to begin. A lot of the knowledge that we have generated on provider payment method tend to be looking at how does changing provider payment method for a single facility affect their treatment and their behavior. And I'm going to argue that we probably need to start thinking about provider payment method, looking at the whole system together, the whole delivery system together, rather than a single clinic or a single facility within the whole system. We probably have to start thinking about provider payment method steering towards population-based thinking rather than facility-based thinking, and I'll illustrate to you why. The second missing bit in the literature is that I think that there's still very little evidence on how provider payment method actually can or cannot affect quality or outcome of care. And of course, the recent work on pay for performance is very much along this line. And I would say that in the advanced economy, the result based on to what extent pay for performance is actually effective, I would say that the results are rather variable. It depends, it is very highly dependent on context. In low and middle income countries, of which I think a lot of you are also working in or interested in, the major results that we get from result-based in pay for performance is mostly on maternal and child health. For the rest of the services, the evidence is again very thin. And we have very, very little evidence on whether pay for performance or pay for quality actually work at the hospital level. The experience in the United States is actually not too promising. The experience in England was more promising in the short term, but then longer term evaluation seems to demonstrate that it is not quite sustainable. And if it is but the evidence in low and middle income countries is almost missing. And then finally, I think that the third gap in the provider payment literature is quite often when we look at how payment for a hospital or a facility changes behavior, there's a big black box within. In other words, how does that incentive get translated to the individuals who actually decide what treatment is being done? And so this echoes with the recent attention to management as an important factor to pay attention to in the economics literature. So these are the three gaps that I have identified, and we're trying to look at different opportunities to do different kinds of interventions and experiments to see how the knowledge gap in these three questions can be closed. So the work that I'm presenting is actually in China, in fact, in Guizhou province. And for those of you who come from China or know China, know that it is actually the poorest province in China, in the southwest, with about 60 million population, no, 60 million population. Sorry, 10 wrong. So what is the policy context? The policy context is that, to make it brief, in the last 10 years, China actually has established public health insurance schemes to cover the entire population. For the rural area, there's a scheme called the New Cooperative Medical Scheme, commonly called NCMS. But the evaluation of that experience is that, yes, the impact has been people are using a lot more service in terms of many, many more visits, many, many more admissions. But in fact, expenditure or people's out-of-pocket payment has not changed, or in some cases have even gone up. So you might be puzzled by why insurance coverage would actually lead to even higher out-of-pocket expenditure. And one of the main reasons, not the only reason, one of the main reasons is that we also now learn in other countries, if insurance expansion is coupled with a fee-for-service payment system on the provider side, in fact, you will lead to motivation for the provider to do a lot more service and a lot more intensity in terms of services, leading to cost escalation. So within the Chinese context, even with the latest national policy declaration, is that China must reform its provider payment method. How the insurance should pay providers needs to move away from fee-for-service. So the national government is actually encouraging the local government to pilot and try out different models that would provide a better solution. So it is within that backdrop, against that backdrop, that we went to Guizhou to try to work with them on an experiment. Now, just a little bit of a background on rural China. I'm going to be just focusing on rural China today. In rural China, is this right? On the delivery side, it has a 3-level delivery system. At the top is the county hospital, which will be more equivalent to most of what you will be familiar with as a district hospitals in other places. And beneath that are township health centers, and they're like community health centers. And then further down are village health posts. They're a little bit like community health stations in other countries, if that helps you to think about it. Now, I have these very pale arrows. It's not just because I choose this color, it looks good. It's to illustrate that on paper, the government actually think of them as an integrated 3-tier delivery system. But in practice, there's actually no connection among these 3 tiers at all. It's a fragmented delivery system. And again, I think many of you who work in developing low and middle income countries will find this very familiar, okay? Fragmented system. And on the demand side, on the insurance side, almost 96% of the population are already covered by a publicly funded insurance scheme. 90% of that premium is paid by the government, and people only pay about 10% of it. And people can seek care anywhere that they want to go to. There's no gatekeeping system. And many people actually like to go outside the county. The county is the geographic administrative unit of a rural area. And that's where the risk pooling of this insurance fund is at as well. But people can go out of the county to a big tertiary hospitals to seek care. There's nothing to stop them, okay? So this is the background. Now, when we look at the data, what we show is that if you take the entire population that is being insured by an insurance scheme of one county, about 15 to 18% of that population's admissions, hospital admission, is going to the big tertiary hospitals. But that makes up about 50 to 55% of the total expenditure, or the total insurance expenses. So you might say that, well, doesn't surprise you, because If people go to a tertiary hospital, they must be going to seek care for cases that are very complicated and expensive. And a further analysis of the data show that that is not the case. If you take that half of the pie that I just illustrate and said that is that the tertiary level expenses that make up the total pie, about 15% or so is really for people who now are working as migrant workers and therefore do live in the city. Another percentage, which is about another 17, 20% of them, is because they have health conditions that are very serious, like cancer, that a county hospital is actually incapable of treating them. But the biggest part of the pie are actually people who live in the county but travel out of the county to go to these big tertiary hospitals to seek care for health conditions that are quite simple and straightforward. By simple and straightforward, I mean health conditions that a county hospital are very capable of treating. So then the question is, if we can change the delivery system so that the people who are now seeking care at the tertiary hospital for simple problems will now actually stay at the county hospital. In fact, it's more convenient for the people, and also it will be less costly. Because when we compare for the same health condition, when someone seeks care at a county hospital versus a tertiary hospital, the expenditure difference can be as high as 6 times. Sometimes it's 3 times, but on average, I would say 4 to 5 times. So imagine that if that money can be saved, that can be used to fund a lot more other things. So that's the motivation. So you might ask, what is the reason of people living in the county traveling out of the county to go to a big hospital to seek care? As an economist, you would try to think of it as demand and supply side reasons. One of the demand side reasons is that, well, the insurance fund, when it was first set up, it mainly covers inpatient services, and there are also not a lot of differentiation between whether the patient seek care at a county hospital or going to a tertiary hospital. So a patient might feel that, oh, if I go to a tertiary hospital, I think they get me better care, and the price difference is actually not that different, so why not? But that's actually a wrong perception, because even though the copayment rate might be very similar, but if you seek care at a tertiary hospital for the same health condition as a county hospital, in fact, it is a lot more expensive. But by then, the patient has already gone to the hospital. They won't change their mind then. The second reason that is commonly cited is that people just don't think the county level hospital quality is good enough. They just don't trust it. And again, many of you who work in low and middle income countries find this a very common phenomenon. People think that community health centers are poor care quality, so they bypass. So they go to a higher level facility. The third reason is that in China, there's no gatekeeping system. People are free to go anywhere. The fourth reason is that providers at all levels are actually paid by fee-for-service. And so imagine if someone has already shown up at a tertiary hospital, the tertiary hospital has absolutely no incentive to send the patient back to the county hospital because every patient at the door is business for them. So what might be some of the interventions or solutions to deal with this problem? Well, the Chinese government has already tried to deal with, oops, what did I do? So the Chinese government is already trying to deal with this problem by changing the benefit package in the sense that if an insured person living in a county, if they don't get referral, they can still go to a tertiary hospital, but then their reimbursement from insurance will be reduced. So that's something that has been done and is widely being scaled up in many parts of the country. And so we went into doing this intervention with the following rationale behind. Well, even if people know that now their insurance reimbursement is bigger at the county hospital, if the county hospital service is not there, they were still not seeking care at the county hospital, or if they think that the county hospital's quality of care is not good enough, they still won't want to stay there. So whatever that we design would need to have built in an incentive for the county hospitals to want to actually build up their service capacity and also improve quality. Those are slightly two things, right? Quality versus the new things that you can do. And we also want to give the county hospital an incentive that for whatever service that they do, new things that they do, high quality things that they do, they also would be cautious enough and conscious enough to only use the minimal resources to do it. In other words, cutting costs and including reducing expenditure. So with that in mind, we launched a social experiment. The intervention is mainly targeting the county hospitals to give it incentive to build up its service capacity, to increase its quality of care as a way to allow them to be better gatekeeper, to keep the patient at the county level, but only for the service that they're capable of doing. And therefore reduce the unnecessary spending at the tertiary hospitals so that there can be savings to improve other service. Okay, so that's the goal. And, the intervention is a global budget plus a pay for quality. So the county hospitals is given a prospective global budget, and all of you sitting here know that global budget would give hospital incentive to actually reduce their expenditure, but it also gives their incentive perhaps to do less. We don't want them to do less. We actually want them to do more. So in the next slide, I'll explain a little bit of how we actually design this global budget to incentivize them to do more. And at the beginning of the year, they are only given 70% of the budget. 30% of the budget is actually withheld for mid-year and end-of-year quality evaluation. And so that fund, the remaining fund, is dispensed to them based on how they do in terms of quality of care. Now, so you would say that all of you who study economics would say that, well, you give them a global budget, they would do less. Yes, they would reduce expenditure, but they would also do less. And how does it actually would incentivize them to try to keep patients that they can treat at their hospital rather than referring them out? So the key is, how do you incentivize them to keep patients that they can treat? How would we design an incentive that would find it profitable, to say it bluntly? So we first of all take the entire county's population's distribution of health conditions for hospital admission. Let me rephrase. We take the entire county's population's hospital admission in the last few years, and then look at what are the health conditions for hospital admission. And we divide them into three groups. One group of the health conditions are health conditions that county hospitals has all the personnel and equipment to treat well. So for example, simple things like treating appendicitis, normal delivery, pneumonia, those will be that kind of services. There will be a set of services that the county hospital would absolutely have no ability to treat. They're mostly cancer. But there is another group in between that the county hospitals actually have equipment, but their doctors don't have the perfect knowledge or skill to use those equipment to do a diagnostic or to do a surgery. Okay, three kinds of services. So how do we devise the budget? If you look at these three kinds of services, we decided that for health conditions that the county hospital cannot treat, of course, it should not be given as a budget to the county hospitals. So this part of the expenses is left with the insurance fund, who would then reimburse anyone who go to a tertiary hospital for these conditions separately. For the health conditions that the county hospitals can treat, has the ability to do so, we separate them and look at, in the last 3 years, how many of those admissions are actually treated by the county hospitals? What is the average expenditure per admission? How many of those admissions actually has gone out to a tertiary hospital? And what is that expenditure per admission? And we do that for every single health condition for the other category. That is the category that the county hospitals has some limited ability to treat, but not quite well, so they need some assistance. And in doing the budget, the idea is you give the county hospital a budget which would include and to encompass the service volume that they're already quite comfortable in doing, priced at the expenditure that they have been delivering their service. And we get them to try to, and we then say to them that, look, Q2 amount has gone out of the county. We now give you that budget as well. And not only that, we're going to give you that budget not at P1, which is your price of doing the service. We're giving you that budget at a price which is slightly better than P1. In other words, the more you do, the more profit margin you're going to be able to make. And for the second set of services, which are the more complicated ones, we again negotiate and discuss with them. Of all the volume that last year has gone now, can you commit to saying that X% you will be able to treat? So this is like a pre-negotiation. So then this part of the budget is calculated as what they did before at their own price, plus also what had flown out previously, but now they think that they will be able to attract them back. And again, at a price between their own price and if it had been treated at a tertiary level hospital, but much closer to this end. So again, we're basically telling the hospital that if you can develop your capacity to do more of end services, you're making more profit. And over time, your budget keeps increasing, and over time, you can do more of that, and over time, your budget will get bigger. So that's the incentive for them. And so what are some of the quality metrics? I'm not going to go into detail. So we basically take what is commonly used in advanced economies on a number of health condition-specific process measure, plus other condition-specific measures. For example, using the surgical checklist, surgical site infection. I'm not going to go into details. So what is the incentive supposed to produce? They're supposed to reduce unnecessary referral, because now the hospital, the county hospital, know that the more it does for, I keep doing that again, sorry. So again, is the more they do Q2 and N2, that is what previously has been referred out, the more profit margin they can keep. And in particular, they want to improve the hospital's capacity so that they can do service N. That is, previously, patient might show up and say, I'm not quite sure if you're the best person, but over time, patient would want to come to them as, I'm confident that you can give me that service, okay? And then also to improve quality of care. And of course, this is very, you can tell that this is a pretty complex intervention. And so this is going to be quite dependent on whether the hospital is able to adjust its management in order to take advantage to the incentive that is built in there. You should tell me when you want me to stop, okay? So the framework is intervention, provider payment intervention with the intention to produce these outcomes: reduce expenditure, reduced unnecessary care, but also improve quality. But this is also done in the context of the hospital building up its capacity. okay? Being able to treat more complicated cases. And we try to unpack the black box of what is internal management that is allowing them to take advantage or not take advantage of that. And I'm not able to present to you all the evidence today because we haven't gotten to implemented them, all of them. So the idea from the Chinese government's perspective is, can this kind of incentive scheme versus a very facility-based incentive scheme going to help them to change the resource allocation to reduce spending at the very top level that might be unnecessary? It's an experimental design, and so we do a pairwise randomization of about 58 counties. Each county is about, the population of each county is about 300 to 500 thousand in terms of population. And so of the 58 county and 29 pairs, we then randomly separate them into phase 1 and phase 2 intervention. And phase 1 is 2016, and so since it's just middle of 2017, what I can show you is definitely still very preliminary observations only. The control area continued to be paid by fee-for-service with a limited number of case-based payment. In both treatment and control area, the insurance benefit package is almost identical. And how do we measure internal management? We use the World Management Survey, which is, I think now many of you are familiar with, and that's also the same survey that Carol Popper referred to yesterday. So there are 4 dimensions of it. One is on operation, on performance, on target, and then on people. So trying to look at the different aspects of management that in the literature has proven outside the health industry to improve the performance of a firm or in education. And in terms of healthcare, what we have known, what we now know is that better performance in management is associated with better health outcome in terms of quality, and also better financial performance of the hospital. Okay, so but then the other effects of it on its effect on other outcome, and also how it interacts with any policy intervention that's much less known. I won't go into the detail of these. So this is just to show you the baseline comparison of our treatment and control area in terms of some of the outcome variable, expenditure per admission, out of pocket, length of stay, readmission rate is very different. I don't understand why. The number of beds of the facilities in both places, number of staff, total revenue, they're all very similar, and even the management score is very similar. So the baseline is pretty similar. Now, this is a dummy regression, so don't pay attention to it. You might be saying that, oh God, this is so small, I can't see it. But I put it in a way that is so small and didn't bother to separate out is because I was going to tell you that you actually don't need to see it. Why? Because what are the hypotheses? The first hypothesis is that if this works, the county hospital will be expanding the scope of service that it is able to do. And if that's the case, it could turn out that it would increase expenditure because it is actually treating more complicated cases. It is possible that it would actually be increasing length of stay even, because Chinese hospital has a habit to sort of readmit patients under fee-for-service. So this scheme would actually incentivize them to reduce unnecessary readmission, but that actually might then become longer length of stay. So this is just a very crude analysis that hasn't unpacked all the interventions, and in fact, the analysis needs to look at of all the Q service that I showed earlier, the ones that the hospital are capable of doing, are they reducing unnecessary use of service? Of the N service, that the one that they are supposed to attract more to them, are they able to do that well? So it should be a separate analysis. But what are some of the observations? This is only 1 year into the intervention. The intervention is very complex and change will definitely take time. Second is changing behavior is very difficult. we go to talk to many of the hospital directors, and many of them actually understand in verbal terms what the intervention is, but have they changed any internal management? I'd say almost nothing. And there's a bad design, there's a weakness in our design as well, because all the incentive is targeting at the county hospital. But patient can still freely flow to the tertiary hospital. There's no companion policy to make the tertiary hospitals also has an incentive to want to send the patient down. So the county hospital director complained to me and said, Professor Yip, you're giving me such a difficult job because every patient I'm not able to convince to stay there and go to a big tertiary hospitals, they never return to me. Well, I said, of course, because they're paid by fee-for-service, the more they have, the better. Why should they return to you? And this shows how complex these kind of design can be if you really try to deal with it from a systemic way. Information requirement is very intense to implement it and also to evaluate it. And it also raises a question which I think Alan might also be speaking to, that is, when we are now dealing with more systemic kind of problems that require more systemic kind of interventions, that is not just one single clean intervention, the traditional use of RCT in the economics literature, is it creating a barrier for us to ask good questions? Or is it the gold standard still for these kind of work? But I would still say that given all these complications and difficulties, it is about time in the provider payment literature to move to the next generation of thinking that would be taking more of a systemic approach. And I think this is what we are seeing in the United States. Many interventions is about how you design provider payment method in order to bring about integrated delivery, in order to bring about what ACO is trying to do. So you're going further away from provider payment for a single facility. And I say that this question of how do you actually align incentives to promote a delivery system that involve multiple provider and multiple level of facilities is a key question that we need to address from both an academic perspective and also from a policy perspective. And this study has a lot of collaborators. I'm not going to show them because you won't be able to see them. There's so many of them. So thank you very much.
Okay, I should stay close to the mic. Good afternoon, and thanks for showing up in such large numbers. Very happy to see that. Thank you, Winnie, for that presentation. While Winnie talked a lot about provider incentives and randomized controlled trials at the supply side of the healthcare system, I'd like to use this opportunity to talk about incentives and RCTs targeted at the demand side of the healthcare system. More specifically, I want to talk about extending coverage through voluntary health insurance. How do I flip this? Keyboards. Okay, so you've all seen this box, I'm sure, many times, the WHO cube reflecting the different dimensions of universal health coverage. So you have the who is covered, the which services are covered, and what proportion of the costs are covered, right? So today in this talk, I want to talk about the who is covered and the extent to which it is possible or not to increase the share of the population covered by health insurance through voluntary health insurance. I'm not going to talk about one specific RCT. I'm going to talk about a few research projects that I was involved in some way or another, to try and link the questions on how to increase coverage, how to maintain coverage, and what are the effects of voluntary insurance on the non-insured. The reason I want to talk about voluntary insurance in this talk is not necessarily because I think that's the best way forward for many low middle income countries, but because you do see with UHC ranking very high on the policy agenda, many low and middle income countries are thinking of getting to UHC or moving closer to UHC through an approach of social health insurance schemes, which involve voluntary health insurance for a large proportion of the population. And I guess the most famous examples of social health insurance are in Asia, Vietnam, Indonesia, Philippines. And before, so I was at Erasmus University doing research on Asia, Southeast Asian countries. I recently moved to the bank where I'm working in mainly West Africa to realize that even in African countries at fairly low stages of development, Sierra Leone, Liberia, Guinea, West Africa, they're thinking of moving towards UHC through the rollout of a social health insurance scheme. Now here, all these green countries are countries that have some sort of social health insurance. In most cases, it's restricted to civil servants or private sector employees. But in many of the countries, they're actually thinking of extending it to cover increasingly the informal sector. The big example for many countries, and probably the most known, is Ghana, obviously. The problem with this approach is, of course, that while these countries have and are experiencing substantial economic growth, this economic growth does not coincide with the formalization of the workforce. This chart here shows you the fairly flat trends in the share of the informal sector in this case, Philippines, Indonesia, Thailand, and Vietnam, in a period during which there was substantial economic growth. So while GDP rises, the share of the population working in the formal sector doesn't increase by much. And I've been trying hard to produce a similar graph for Sub-Saharan Africa. It's quite tricky because I couldn't find sufficient trend data. But you can imagine in Sub-Saharan Africa, the levels of informal sector or informality are even higher. This has important implications because it means that it's very hard to raise a lot of revenue through tax on wages, which is a core component of social health insurance. So this limited fiscal space in many low middle income countries leads to a situation where there are resources to cover the poorest 20 or poorest 40% through general tax funding, and where the formal sector, the top layer, is covered through compulsory contributions through taxation on wages. And I have to pay credit to Ellen Wagstaff for coming up with a hamburger representation of this, what we often refer to missing middle. Because what it means is there's sufficient resources to cover the top formal sector layer, and there's resources to exempt the poor from paying premia, but then we're left with the big missing middle, where the hamburger is supposed to go, the big missing middle of the informal sector, which is supposed or asked to voluntarily enroll in health insurance schemes. Now, the reality is that very few households do so. These are some random numbers, I have to admit, from a random selection of countries: Philippines, Ghana, Vietnam, Indonesia. And I also have to be careful because it's very hard to find this data, actually. I've been looking for it, and there's a lot of discrepancies between whether you look at the numbers published by the health insurance agencies or data coming from survey, I think because of reasons of awareness and official statistics not updating regularly. So this is tricky, but the point I want to make is that you do see in these countries the large majority of households in the informal sector does not take up voluntary health insurance. Ghana, which is the country that is often considered to be an example for many other countries in the sub-Saharan African continent, only has a coverage rate of 40% of households. And importantly, more than 60% of the members are covered under the premium exemption scheme. So again, very few households actually pay insurance premium. Okay, so this is a problem, this missing middle. It leaves us with a lot of big proportion of the population uncovered by health insurance. What to do about this? How can we increase this share? Well, we could wait for the informal sector to formalize, but if you remember the trends I just showed you, that could mean waiting for a very long time. We could give free entitlement to the entire population, so fully tax-finance healthcare, which is what has been done in Thailand, for example, and which is a very fast and effective way to get to UHC, but it also would require, for many developing countries, substantial structuring reforms to increase the government's budget. And the feasibility depends from one country to the other. The third option is then to increase demand for voluntary health insurance. Can we convince more people of voluntarily buying into these health insurance schemes? So in the remainder of the talk, I'm going to talk about this point 3, and I'm going to present some experimental evidence on whether and to which extent it is possible to do that, to increase the demand for voluntary insurance. Now, if we want to increase the demand, we need to first think about why it is low. Why is uptake of this missing middle so low? There's 2 reasons, right? Either they are too poor, the premium is too high, or they're not willing to buy insurance because they don't understand why insurance can be useful or why it's good to have, or because the insurance product is actually bad value for money. If it doesn't offer financial protection, if it has a shallow benefit package, then why would people be interested in buying it? Or because of limited risk aversion. People might actually be willing to take the risk, to save their money and take the risk of falling ill and suffering financial catastrophe. Now, if you would ask households, most survey data would tell you that it is because the premium is too high and people don't really understand what health insurance is about. So if you believe those are the 2 main reasons for the low uptake, then lowering the price and increasing people's knowledge should lead to higher uptake, right? And this is a research question that's been looked at by colleagues of the University of the Philippines, together with Adam Wagstraff from the World Bank, where they used an RCT to try and answer the question of, can we increase uptake, in this case in the Philippines, PhilHealth coverage? Can we increase uptake of PhilHealth coverage by reducing the price, in this case by a 50% subsidy for 1 year, and by providing information, and by having SMS enrollment reminders in this case? So can we, by lowering the price and increasing knowledge, can we increase uptake of the insurance? And this was done in the context of a randomized trial. Interestingly, they find you can't, at least not in the Philippines. You see in this chart, uptake of PhilHealth insurance among the controls is 10%. So this again shows the fact that people do not take up voluntary health insurance to a large extent. It's only 10%. Among the treatment samples, so the sample that was exposed to the price cut and the information campaign and the SMS reminders, uptake is 15%. It's a 5 percentage point difference. It's a bit disappointing, right? We're not getting much further through this intervention. Obviously, researchers could see this coming. I mean, they could see that the vouchers were not being used and that uptake wasn't moving. And interestingly, because of the SMS reminders, people started to text back with reasons why they didn't use the vouchers. So researchers got a sense of why it is that people were not buying into PhilHealth. And they started to understand that the high transaction costs of filling in the form and submitting it to PhilHealth, which in many cases meant traveling to the district capital, traveling a substantial distance, that was an important barrier for non-enrollment. So they conducted a follow-up experiment within the original experiment where they looked at whether to which extent they could increase uptake by helping people filling in the form and by actually submitting it to the PhilHealth office. Interestingly, this additional intervention, so it's like an add-on to the original RCT, this additional intervention raised uptake to 40%. So this is quite a lot, and it shows that actually the transaction costs of getting insurance in this particular case are perhaps a larger barrier for enrollment than the actual cost of the premium. Now, it's not obvious whether helping people to fill in a form and submitting it to the PhilHealth office is not an intervention you can easily imagine taking to scale, right? It's very intensive. But it does, you can think about other ways to reduce transaction costs by allowing people to register in local pharmacies, or, there are policy interventions that could address the transaction costs other than actually sitting with households filling in the form. Now, this is, I think, nice to see that you can increase uptake. At the same time, I think you need to realized that even with this very intensive intervention, 60% of the missing middle is still not insured, right?
Can you help us to understand what the cost of insurance is compared to median income of this people? I mean, it makes a difference if they're being asked to pay.
Yeah, sure. Yeah, that's a valid question. I don't have that detail with me at the moment because I'm talking through many trials in a relatively general way. So I can't tell you exact numbers at this time. It's heavily subsidized though. I mean, these insurances are not actuarially fair. I mean, they are heavily subsidized by the government and the premium is not extremely high. But at this point, I can't tell you much more than that. But it's not, I mean, and also these results do suggest that transaction costs, if they're more important than premium, it's not necessarily the price of the premium. And I think it also raises the point that if you ask people in surveys, why don't you get health insurance? You usually get, it's too expensive. That's actually not the right answer because then we would have seen uptake shoot up much more. But I'm happy to talk about that in more detail later. Okay, we got very similar results. Adam Wagstaff and colleagues did a similar experiment in Vietnam, very similar results. Despite subsidies, leaflets, even a video to make the concept of insurance more salient, uptake remained below 5% of the target population. This study didn't look in particular at the transaction cost issue, but what they did do, and what I think is very interesting, is they asked government officials before doing the RCT what percentage, what impact they were expecting from the interventions, both from the information plus subsidy, from the subsidy only and the information only. And the interesting thing you see is the more you move down, so this is basically levels of the healthcare sector from very high policy level to closer to actual the level of service delivery. The more you move towards the level of service delivery, for example, the head of the community health center, the more pessimistic people are about the effects of the RCT. I think this is really interesting, and I think in hindsight it's probably predictive of what the RCT showed, that the intervention was not successful to increase uptake. And I'm thinking that perhaps these type of qualitative assessments we should do more often before doing an RCT, to understand whether the RCT we're running is actually addressing the core problem as perceived by people delivering services. There is some other evidence on this topic, although it's very limited. Most studies are observational. There's only few RCTs, but generally, the ones that I know of and that I could find show that information, providing information on the usefulness of insurance doesn't increase uptake. There's some evidence from Ghana, Nicaragua, Burkina Faso. In Burkina Faso, it did increase uptake at the margin, but uptake remains at 2%. So there's some good evidence on Mexico, but I think that intervention was much more than an awareness-raising intervention. There was also a lot of other investments made. And there's evidence from India showing providing information doesn't increase uptake. And I think it's really important because, again, I think in many of the countries that are in Sub-Saharan Africa that I started talking about, that is the approach that has been taken, is to roll out awareness campaigns and promotion of health insurance, which I think from the evidence we have, we would expect to not be very successful. There's little evidence on the effect of price cuts, experimental evidence that is, and at the same time, there's very little evidence on what happens after the RCT ends. And I think this is really important because if you do an RCT where you provide vouchers or a subsidy for a limited period of time, then the experiment ends, the government is unable or unwilling to maintain that lower price level, what happens? There's limited evidence because most experimental studies don't have a longer follow-up. I found one paper in Burkina Faso showing that there was a drop in uptake when subsidies were removed. There's some very preliminary evidence on the Philippines suggesting a positive long-term impact, but that remains to be investigated. And when you think about it, the effect can go both ways, right? There can be an anchoring effect to the extent that people get used to the lower price and therefore they lower their willingness to pay because that's the price that they associate with the product. But there can also be a learning effect. People, through being insured, people start to understand the usefulness or not usefulness of health insurance and therefore change their willingness to pay. So this is important, that the learning effect can go both ways, right? If the insurance does not provide value for money, if it doesn't offer improved access or financial protection, people are going to realize that and they're going to drop out the year after when they need to re-enroll. And an example of this negative learning that I think came out quite strongly in an RCT that I was doing with colleagues in Erasmus and in India, an RCT of community-based health insurance in Uttar Pradesh and Bihar. Basically, this RCT tried to evaluated the effectiveness of community-based health insurance in India, in these two states, in a few districts. The design was a step-wedged RCT. So basically, we had a period of 3 years. In every year, one random third of the target population got offered to enroll in CBHI. It was a new product. There was a lot of emphasis on awareness raising. I mean, at some point, we even made a Bollywood film showing the greatness of CBHI. There were ring tunes, theaters placed. I mean, it was a lot of a very costly and heavy emphasis on awareness raising. There were a lot of community consultations, community involvement in the design of the benefit package. So it was really very community driven. I think because of that, we initially got fairly high uptake. For a new scheme, I mean, we got initial uptake of 23% of individuals, 40% of households, which is a lot for a new scheme. I think we were quite happy to see this in year one. The problem is, and remember we followed people over a 3-year period, the problem is every additional year we lost 50% of the enrollees, meaning that by the end of the study period of the initial 525 households enrolled, we were left with only 135. From the evaluation, both the quantitative one and the more qualitative work, we understood that the main reason for this dropout was the ineffectiveness of the scheme, the shallow benefit package, because it was not subsidized. I mean, rolling out an unsubsidized scheme in a poor village means that you're left with a fairly shallow benefit package. The capitation system provided perverse incentives for primary care providers to distribute fewer drugs and do less. So people were very unhappy with the coverage that the scheme was actually providing because of the benefit package and the provider incentives. And I mean, and this seems like it makes common sense. I mean, it makes perfect sense, right? But it's really important to remember that if scheme is not perceived to deliver value for money, if it provides some theoretical benefit package that is not there in practice, then incentivizing uptake is useless. There's no point to doing RCTs to incentivize uptake into something that's not worth buying. Because then if you push hard enough and you develop movies and whatever you want, you can get people probably to buy into the scheme for 1 year because they want to get rid of you at some point. So they might enroll, but then they will disappear after year 2. So I think ongoing research should really have that issue in mind, that we should only be talking about incentivizing something that is worth having. And then a final point that I think is not often looked at is what are the effects of voluntary insurance on the non-insured? I think one of the reasons this is not often looked at is because it's very hard to do in an experimental setting. You can't do an RCT. I mean, voluntary health insurance is inherently, it's a choice, right? You can't randomize it. So it's very hard to design an experimental study to measure the impact of voluntary insurance on the non-insured because you can't randomize people into not taking up voluntary health insurance. That's inherently not possible. So we tried to look at it together with a student in Rotterdam, Ignat Monfrère. We tried to look at this issue in the context of the Kwara State Health Insurance Program in Nigeria. This program consists of facility upgrades plus a voluntary health insurance scheme. Again, heavily subsidized. Premiums in this case are very low. Despite that, uptake is only 23%, again showing that voluntary uptake is usually very, very low. What we try to do in this study is to compare healthcare use and spending of the insured people, those that selected into the scheme, with the uninsured. And I know for those of you, I mean, this is tricky, right? Comparing insured with uninsured is very tricky because of selection bias. There's reasons why people select into insurance. So this is not an RCT, it's not an experimental study. I do think we can do a better job than most other studies because we have a lot of data on personal characteristics, risk aversion, time preferences, so changes in self-assessed health. So I think we can correct for the adverse selection to a better extent than many other observational studies, but still this is very non-causal. It is interesting, though, that we see that while healthcare use among the insured goes up and spending goes down, as you would expect from a well-functioning insurance scheme, we see that those upgraded facilities are not used more by the uninsured people. And at the same time... No, upgrade... Oh, that's a typo. Thanks. Yes, that's a typo. It's uninsured. Yes, sorry. So upgraded facilities are not accessed more by the uninsured, and we see that their spending goes down. And we have difficulty figuring out why their spending goes down. There is some evidence of them using less costly services, and we have some evidence of prices going up for the uninsured in those upgraded facilities, because they have nicer facilities now, which have led to prices going up. But this is quite suggestive. I think we need to look at this a bit better. I do think this is, the reason why I still want to mention, even though the talk is on RCTs, I think it's really important because in most of these voluntary schemes, I showed you that you have 70–80% of the target population ending up non-insured. If that means that they have worse access to facilities, that's really a problem because those negative externalities then apply to the majority of the population. So I think this is, even though I think a lot of research will end up being descriptive, observational, because of the difficulty measuring this in an experimental way, I do think it's an issue we should look into more carefully. Okay, so to conclude, there were two options to somehow get some meat into this burger, either tax finance or try to increase the demand for voluntary premium-based insurance. And I think from all of the evidence that I've just been showing you, I think it's fair to say that it's unlikely we're going to get towards UHC or close to UHC through voluntary schemes. There are some examples, like the China case that Winne was talking about. I think these are quite different. They're heavily subsidized, and there's a lot of political incentives to get high uptake. Ethiopia, Rwanda, perhaps other examples. These are perhaps not that representative of social health insurance type of schemes like we've seen in Asia. We also have to recognize that few countries will be able and willing to fully tax finance for the entire population anytime soon. So I do think that we need some more experimentation on how we can get uptake to increase in the short term. I think what this evidence might suggest is that we need to be more aware of the transaction costs of getting insurance, but we also need to understand that standard education tools are probably not effective and are not going to get to a higher uptake. I think there is some scope to leverage insights from behavioral economics, so try to have group discounts, to leverage social pressure, coupons that people can spend at pharmacies to leverage present bias, have a no-claim bonus, or make the messaging much more salient. So I do think we can do a better job in raising voluntary demand than just having standard leaflets and SMS reminders, which I don't think are the most effective. And very importantly, we need to, before I think any of us should be engaged in further of these RCTs, we need to think about whether schemes are providing value for money to make sure people are enrolled. And this seems like such an obvious point, but it is an issue because in many of the African countries I was referring to before, social health insurance and rolling out, offering voluntary insurance is seen as a mechanism through which to raise more public money into the system before the supply side is fixed or before the supply side is improved, before there are actually staffed facilities in rural areas. And that is really an issue because then, I think that reasoning doesn't work. You can't expect people to buy into a scheme before you actually have something to offer. So we need to think about the sequencing of events. Finally, there's a danger that voluntary insurance schemes leave a large part of the population actually worse off, which is something I think we need to pay more attention to. So in sum, I think this could be a very interesting research agenda in countries that are now seriously planning to roll out these insurance schemes could benefit from that. I also really think that we need to realize that perhaps even a more interesting and important research agenda is the one of how to increase domestic public resources for health. And I also think this is a research agenda that we can't answer very well through randomized controlled trials. And that echoes a bit the point Winne was making before, that some of the perhaps most pressing questions in health financing and health system strengthening cannot be easily answered by an RCT type of approach. So we shouldn't lose sight of those questions either. Thank you.
Thank you, Winne and Ellen, for really interesting presentations. And I'm sure you'll have a lot of questions. We have about a half hour for question and answer time. If you could come up to the microphones, that would facilitate everyone hearing your questions, and sort of line up. We've got one microphone here and another here. Is that? And we'll just go in order and sort of back and forth between the two. Yes?
Okay. My name is Bill Savadoff. I'm at the Center for Global Development in Washington. I wanted to reflect on the last presentation. I had done some work on community-based health insurance back in the early 2000s, and sort of very similar kind of thing about how hard it was to get uptake. And so I had one question and then just one sort of provocative thought. The question is, the whole idea of doing this is to be able to, I mean, the two things you laid out there were, expanding coverage for this missing middle through taxes, sort of a time model, versus the voluntary payment scheme. Then, in order to get people to enroll, you lower the premiums so that it's affordable, and then you've reduced the amount of money that you're bringing into the system, and you're still trying to expand it with this subsidized premium. So at some point, the cost of creating this whole voluntary insurance scheme just seems like you've gone down a road, or the country's gone down a particular kind of road that's ultimately self-defeating. It's not really getting you anywhere. The more provocative comment is I was trying to do some research on why people don't buy health insurance, why the poor don't buy health insurance. And as an economist, I think backwards from most people, right? So I think poor people should really want insurance because they can't afford the health risk, whereas the rich people can. And when we did some focus groups and stuff like that, we found that the same people who would not buy health insurance were buying lottery tickets. And so we started thinking, well, they must understand risk in some way that's different from the way we understand risk, because I think the lottery ticket is a complete throwaway, whereas the health insurance is a bargain, because it's subsidized 90%. And we didn't try this, but the direction I was going was thinking, why not, instead of trying to convince people that this is a value for money thing, why not sell people lottery tickets, which also come with health insurance? So you build into the cost of the premium, I mean, maybe 1 penny is for the lottery and the other 99 cents is covering the insurance premium, but it's essentially asking people what is it that they value and then selling that to them and subsidizing the insurance rather than trying to convince them that this is what they need.
Should I do that here? Yes, so thanks. Is this on? Okay, thanks for the comment. I didn't mention that point of the cost effectiveness of raising premia, which I think is very valid. Also, I mean, you saw that in Thailand. At some point, they gave up on the 30 baht because the 30 baht was just not bringing in the money to compensate for the cost of collecting it. So I do think that's a very valid point that we should not forget to use in the arguments, because it really questions I think the extent to which the proportion premium stake in the cost of the scheme is really questionable, and we should make that more explicit. So I think you're right with that. On the lottery tickets, yeah, I'm not sure. I haven't thought about that before. I do think we have to be thinking more about innovative ways of taxing consumption to raise, because when you think of it, I mean, just taxing consumption is a way of making health insurance premium compulsory, right? If you tax on consumption and you use those to fund the insurance, it's a way of shifting out-of-pocket payments to the public budget in a prepayment scheme. And I mean, WHO was very much advocating for sin taxes, tobacco, alcohol. I think, I mean, that's never a bad thing to do. I also think that's probably not going to be sufficient, especially not if that consumption is then going to drop. So I do think we need to think a bit more on innovative ways of taxing consumption. Consumption ideally that is consumption that is more done by the rich, so that you have some sort of progressive system. Whether that should be lottery ticket consumption, I'm not sure. It could be, perhaps. But I do think we should be thinking along those lines a bit more, yeah.
Thanks very much for the interesting presentations. Debbie Muirhead, now University of Melbourne and Fred Hollows Foundation, but I was the AusAid Health Advisor in Indonesia when JAKA-N was being developed, and my question really relates to that. As you said, we had quite a debate, quite a discussion in Indonesia when Jaminan Kesehatan Nasional was being developed about covering the informal sector, and use that evidence from Thailand and another country on the cost of collection being so much higher than covering. But one of the objections that the Ministry of Home Affairs raised repeatedly was that if they covered the informal sector, then the high informalisation would just be perpetuated, and in fact there'd be incentives for the formal sector to informalise their employees. Now, you are seeing with JAKA-N now the formal sector actually manipulating the system, not reporting things well. So, in fact, there's even been much lower uptake than expected from the formal employees. But I wanted to know whether there was any trend evidence on informalisation and that risk actually bearing out, because it wasn't an argument that we could have well.
Thank you. It's a very interesting question. I think Adam Wagstaff looked at this with colleagues. I only know of his study, and I think there's one or two studies looking at that where they do find effects of the insurance leading to, I think it was in the, I will have to look it up. I think there's some evidence suggesting very small marginal impact. So suggesting that there is a very small impact of people wanting to stay in informality if that means that they get tax-funded healthcare as compared to having to work in the formal sector and pay taxes on their wages. So I think there is some evidence on Thailand showing very marginal effects, but not very large. That's all I can. And perhaps one thing to come back to this issue of how to raise additional resources through taxation. The lottery example, one additional issue that I don't know how serious that was, but that I've been hearing in Indonesia is to have even taxes on consumption of electricity at some point, because that is something that is consumed more by the rich than by the poor. Everyone is so I don't know what the status of that discussion is, but it's again another example of thinking about how to tax consumption that ideally affects the rich more than the poor.
I wanted to ask Winne a question, but firstly, just a quick point on the lottery ticket. I mean, the implication of that is that population is risk-loving, because, I mean, you have to be risk-loving to buy a lottery ticket. The expected outcome is less than you pay for the ticket. So there's a tail that you're willing to gamble on, which has implications for buying insurance. I don't think that flows across. I think people are quite segmented in their decisions, but it is a depressing thought. Anyway, my question really is for Winne, which is this fundamental point, which I think reads across into some high-income country systems as well, of, well, what is the incentive? How do you create an incentive for the tertiary institution to actually let people go and not treat people? And I just wondered whether you'd kind of thought about how you might tackle that, because just getting rid of fee-for-service doesn't really necessarily make the problem go away, and what your sort of thinking about that was, both in China or more generally.
I think that there are two levels to your question. One is a technical answer, but there's also a political economy answer. So political economy answer is that tertiary hospital directors tend to be very powerful in all countries. They tend to be going to private dinner with the major decision makers. So it's very difficult to do anything that affects their interest. On a technical level, what we're trying to do in China is this. So basically, they will still be making money. The question is, are there ways that you can set up the incentives such that they actually, for the services that the lower level is able of doing, is there a way to set it up in such a way that they can actually split that profit? right? Because right now is the top tertiary hospitals, they can only earn a profit by doing a lot of unnecessary thing. So if they would stop treating the patient, send them down to the county level hospital, and in fact even help them do that service, the cost actually would be reduced. But you need to set up in such a way that that saving has to be shared by both of them. So that's what we're trying to do. So, trying to test.
I'm Don Shepard from Brandeis University and have a question for Ellen. We have a student at Brandeis from Ghana who's doing an evaluation of the Ghana National Health Insurance that speaks to your last point. It's primarily, well, it's a voluntary system. It's primarily funded through a VAT, a value-added tax. It's a very broad-based tax on all goods and services that are bought in the economy. The enrollment has varied. In the latest data he's reported is only a 46% uptake in Ghana. So it's heavily subsidized, but still requires a modest payment and some administrative hassle. He's reported, Samuel Anawat is the student, and he's reported the reason for the low uptake is that people are not very satisfied with the services that they get at public facilities. So even though the cost is small, it's not really worth their while to join. And so I wonder if you had any comments about how to overcome that barrier, sort of related to your last research agenda. So it's a kind of natural experiment in a country that's tried it, and even the broad-based financing has not shown as much success as one might have wished.
Thank you. I think it's a very good point. It's actually perhaps one that Winnie can answer better because it links to her story. I think that the effectiveness of health insurance type of schemes, it's a different research agenda than the one I was talking about, but it's I mean, it really drives uptake. I don't know that much about the Ghanese system. I know that to a large extent it probably was a problem of the provider payment system initially, where they also had a fee-for-service system, and that increased costs immensely, and now they're moving towards more of a capitated budget for primary care. So I think that question is probably one that relates much more to Winnie's story on how do you pay for healthcare and how do you set financial incentives towards providers in such a way that they're incentivized to produce actual good quality healthcare. So that is, I mean, that's a But
I think it's also a widespread problem in lower middle income countries that people think that when you expand insurance, you will solve the problem of access to care but that obviously common sense would say that if the supply is not there, not to say good quality of supply is not there, people are very smart. I mean, the first year they may pay a little premium, the next year they realize that it's not worth it. I mean, I think it's very interesting from a lot of our work, even if you interview what you think are just farmers, what you think are housewives, you think they don't have economics training, they actually exactly know that calculation in their head. I have paid that premium, and if I'm not going to get the service that's worth of it next year, they're not going to join.
Hi, my name is Patrick, and I work for the Health Policy Plus project, and I have mostly a thought. It's addressed to Ellen. So, Ellen, do you think that the way all these experiments were designed, there might have been a little weakness in the sense that they might have underestimated the true opportunity cost of enrolling these targeted groups into this heavily subsidized insurance scheme, and also the true opportunity cost of maintaining them?
Yes, obviously, yes, I think so, because that's, especially in the Philippine experiment, that's what you tend to see. It's I remember at the time of doing this project that there's people actually texting back saying that they missed the boat, literally, to go to the PhilHealth office to submit the form. So, I mean, if you live on an island, you need to travel to another one. So obviously, transaction costs are really high, and those have been underestimated in this particular case. I think it's very country specific. The other thing that I, looking back, struggle with is to which extent the price cuts that are offered through these subsidies and vouchers, to which extent are they representative of an actual drop in price by PhilHealth? Because I think we perhaps we didn't think about that. I mean, we just think if we offer people a voucher, a 50% subsidy, that it's like a price cut of 50%. But I mean, you get those emails all the time that you want a trip to the Bahamas, right? And it's very different from having an actual policy that's been announced by PhilHealth to having researchers giving you coupons that get you a discount for PhilHealth for 1 year. So I do wonder to which extent, yeah, that they're representative of an actual lowering in the price. That is something that that I'm not very sure about. But I do think that has been hugely underestimated, to answer your question. Yeah.
My name is Wu Zhen from Brandeis University. My question is to Winne. It seems a lot of problem is more about the referral system because China doesn't have this system. A lot of people just go to the tertiary hospital to get all this, get a care, a lot of wastage. I just want to know what is the rationale behind it? Why is designing such a like a payment system instead of helping to develop a kind of a referral system?
So the referral system is the goal, but the government can't all of a sudden tell people that from now on, you can't go to tertiary care unless you go to primary care first and get referred. Because we're human beings. For the last half century, you can go anywhere. No government can just come and say you're not allowed to do that. So in a way, you cannot use regulation or sanctions to stop people from doing what they're used to doing. So what we have been trying to do is let's then work on incentives from both the demand and the supply side and see how much it will help solve that problem. And this problem of referral is not just China's problem, it's around the world. And I think most countries are trying to find out what can be done in order to reestablish this referral. And most countries have found that if you just order people and say that you can't do it, maybe in the first 2 months it works, but then it just falls apart.
Hi. So my question is mainly to Winne. I'm Gabriel Facchini. I'm a PhD student. Basically, on my thesis, I try to look behind this volume outcome relationship or association that has been found, right? I'm trying to see the drivers behind it. But so when you were talking about bring it back to the county hospitals, you know, I mentioned about the effect of volume, right? So I don't know how would it fit in your story or whether it's a settled question. I should drop my PhD and not follow this question anymore. Or
I'm not sure how to advise you since I'm not your advisor, and I don't want to say anything that your advisor would think that I am giving you bad advice, but I don't think what you're doing is so contradictory to what I have been talking about, because I think precisely, if you remember the surface that I separate, the end surface, those are precisely that at this moment the county hospital is doing isolated a few of them. And patients don't have trust, and they don't have the experience, they don't have enough volume to do enough of them to practice and develop quality. So the idea is give them a price such that they actually will be able, I didn't get into that detail, there's a price, there's a profit margin in the way we price it, is to let the hospitals have the flexibility. If they want to invite a senior consultant from the hospital, tertiary hospitals to come down to them, to the county hospital and do the service and train their staff as well, over time they would do more and more volume. I mean, based on your research, is going to improve quality, and then they would then become the expert of that.
Hi, question for Wendy. My name is Aaron Kay. I'm at Microsoft Research.
So in the US recently, there have been a lot of hospital closings, and community health centers have kind of served to replace the role that hospitals have served. Do you know if there's research either in the US or in other places where hospitals have closed and the changes in insurance participation rates in those areas?
Someone from England can speak to that as well, maybe Adrian. My experience in China and other lower middle income country, closing hospital has been very difficult. So most of these, the US in a way is subject to a lot of market forces. So market forces actually does play a role if the big tertiary hospitals in the current sort of very cost control environment is not surviving. There is a possibility that it's being closed. But most of the places of which hospital system is largely, if I would say also, under the public system, is very difficult to close down. Not for pure economic reason. Again, it's a political economy problem. Here's a hospital person coming. Yeah, he's speaking on this point. Oh, I thought you were addressing this closing hospital.
Many years ago, more than I would like to admit, we were working in the Dominican Republic on setting up an insurance scheme for the informal sector. And we were going to piggyback this on micro lending outfits. There's a lot of these lending cooperatives. Some focus on poor women, others focus on different sectors, but there were a lot of people who were borrowing very small sums of money and paying on a monthly basis. So it would lower the transaction cost. But we did some surveys of the people, or actually some focus groups of the members of these cooperatives. They come with different names, micro enterprise associations, and there's even federations of these. And we asked them whether they wanted to be, where would they want to be, get their service? Would it be the public sector in the Dominican Republic was CESPAS? Would it be the Seguro Social, the social insurance, or these other, these private sectors that were in these groups called igualas? And they absolutely rejected the public's. Why would we pay to go to there when we can go for free? We don't even want to go when it's for free. They weren't very happy about Seguro Social because they thought that was pretty bad care too. They would only go with the private sector. We did something similar in Guatemala later on, and it was the same answer, is that they didn't see any reason to pay for care to go to what they thought was pretty bad care. And I think that just reinforced what you said about they saw no value in the public in the public service. Why would they pay more to go there if they really were desperate and had to go there? It was free well, it wasn't really free. You had to pay all sorts of things under the table, but they preferred that. So I think it's really important because it was just a feasibility study of kind of piggybacking, and in certain countries these micro enterprise lending associations are more dominant than in others, Guatemala, the Dominican Republic being two that I know of. So I just thought I wanted to emphasize that.
Thank you. I quickly want to respond to that because it's very interesting. Actually, in the trial we did in India was I didn't talk about the details, but it was very similar. So the CBHI was offered or targeted at women, households of which women were in self-help groups, which is a bit of a similar concept. Women that come together, a group of 12, 13, 15 women that come together monthly and that pool resources that then can be used for common. So it's very similar approach. And we targeted the CBHI to those households exactly because we thought that probably there is more of an understanding of pooling resources and more likely to get such a scheme going, which perhaps also explains the higher take-up initially. And it's very interesting what you were saying about the type of providers being covered, because in this trial, this model that we were experimenting with was very much community-driven. So we played these games, choosing health plans altogether, so letting the community decide and discuss on the benefit package. And one thing that came out is that they very much wanted rural medical providers to be covered for primary care. That was the main preferred provider for primary care, which was to us, I mean, something we struggled with because those are not necessarily well-trained providers. They're not even accredited necessarily. So they are the reality in these rural settings. They are the first point of contact for 80% of the population. They're not necessarily providing quality care. So it was a lot of discussion. Do we want to go? Do we want to now roll out a scheme where we're going to offer cover for something that might be of very low quality and even be harmful? Eventually it was decided to because this was research, we had research money, but we weren't subsidizing the scheme, so it was decided that, okay, if this is the type of benefit package the community wants, so we facilitated that, but then we did end up with a scheme indeed offering rural medical providers, and perhaps that again explains the relatively high take-up. But then, of course, because you can't manage those well in such a small-scale setting, and you can't have verification and good provider incentives, those rural medical providers start to give out way less services, and especially drugs, than they were doing before. So, yeah, I think the story that we in this project is very much similar to what you were referring to.
Okay, we have time for one more question, and then we'll end this session.
Yeah. So my question is to this last presentations. In your, the concluding remark, if you see, you have said that no country closer to the UHC, and country cannot achieve UHC through voluntary health insurance schemes. So, the government have to finance through tax-funded, the insurance schemes. So, but if you see the fiscal space debate, in that the lower middle income country, they are not able to, generate more resources to fund their public provisioning system. So how do you feel that? And even if your last line, if you see that you are not sure how to increase tax resources or revenue to generate more revenue to finance public provisioning or through insurance. Let's say when we are not sure about it and country are not able to raise their resources, so how they will fund the insurance? And even if, let's say, if you are saying that they can raise resources, so why they spend on insurance, why not on provisioning? Why not on provisioning of services? Why to provide insurance? Why not to provide services? Thank you.
I think that you're raising this fundamental question of should government funding go directly to a public facility, or should the funding be going to a third party, such as an insurance, and then the public facilities would now then have to provide service in order to earn that money. It's that fundamental debate about supply side versus demand side financing. And so the motivation of going through an insurance is in system like, India included, the public system is not delivering. If the public system is delivering very well, then there's a reason to debate, is there a need to go through insurance? And then you would have to make sure the insurance actually is really playing a very good purchasing role in order to get the efficiency gain.
Yeah. See, India public sector system is not performing well because of what? Because of underfunding. If you see where, the equally, the qualitative hospitals where, the human resources, equipment, and everything, they are delivering better than the other. Even if you, let's say, the Prime Minister of India fall ill, they go in the public sector.
So this debate, the argument that you made, I've heard it everywhere, manywhere, and we will debate about that again when you have the evidence.
Very briefly on the question on how to raise more resources, we've been looking at this issue for a set of countries that we're working on now in the bank. I think the big agenda for many countries is to raise general government revenue. It's not so much, in some countries, big gains can make by reprioritization and actually spending more of the share on health. Some countries are spending like 3-4% of their budget on health, but the majority of countries that we were looking at, actually just the share of government resources compared to GDP is very low. So it's a much bigger macro-fiscal policy agenda, I think, than just the health sector.
Well, thank you all for coming. It's time to end the session and be around.